Thank you for inviting me to talk about unlocking the mind, the role of psychedelics in mental health treatment. I am Dr. George Mikellides. I am a consultant psychiatrist and a clinical assistant professor at the University of Nicosia Medical School. So when we say psychedelics, this is a class of psychoactive substances that can change the perception, the mood, and the cognitive processes that we tend to see in the brain. What we tend to recognize with most of the psychedelic drugs are acting on the serotonergic receptors, the 5-HT2A in the brain, and that leads to changes in consciousness. Some of the classical psychedelics are LSD and psilocybin, very well known as magic mushrooms, DMT, and mescaline. We are aware that dissociative properties, for example, we tend to see with ketamine, but as well as other psychedelic substances. And MDMA is also another psychedelic that is being used widely, and we tend to see quite good results, for example, in PTSD. The neurobiological mechanism that we tend to recognize, as we said, are acting on the serotonergic pathways and receptors, having an impact on the brain connectivity and neuroplasticity by altering consciousness and perception. Is an important way of acting on the 5-HT2A in a way that this leads to a cascade of reactions, which includes the increase of cortical excitability, which has a significant role in mood regulation and perception. And it's very well known as well that ketamine acts on the NMDA receptor as an antagonist and increases the availability of glutamate in different regions in the brain. The neuroplasticity and brain connectivity, thinking about that this can enhance the synapses, increasing the dendritic growth, enhances in a way the brain network, and has a very huge impact, I may say, as a long-term mental health benefits seen in depression and post-traumatic stress disorder, but as well as in other neuropsychiatric disorders, as new studies are developed and are producing quite good data. Psychedelics in depression, we have seen different clinical trials, including the psilocybin and LSD, and other psychedelic drugs as well. What we tend to see quite clearly is there is a rapid antidepressant effect, sometimes within hours, sometimes within days. And if we do compare this with other traditional antidepressants that might take weeks to see results, it's obviously a very useful weapon to use against depression or PTSD or anxiety disorders, for example. Psilocybin, there are several randomized controlled trials that have shown significant antidepressant effects, particularly in treating treatment-resistant depression. Some of the key studies includes the Johns Hopkins University 2016. A single high dose of psilocybin session led to rapid, sustained mood improvements in patients, which is very important. That was a population that was in cancer patients with depression, which can be very, very difficult as well when we have physical health conditions, especially chronic illnesses. It's even harder to treat depression, for example. We have seen another study from Imperial College London in 2020 where psilocybin was effective, as good as escitalopram, the least to say, for a 6 weeks period in treating major depression. The interesting part, as I have said already, is how fast that this treatment can work when compared to traditional treatment approaches. LSD. We have seen LSD in the decade of back in the 50s and 70s. A lot of studies suggested that LSD may have a therapeutic potential, especially in depression and anxiety. More recently, we have seen the Swiss study in 2022. LSD showed a significant long-lasting reductions in depression scores. even with a single administration, which is really very important to highlight how significant results we might see, how rapid results we might see with the use of different psychedelics. Also, the studies and trials from the Beckley Foundation, LSD microdosing, have indicated mood enhancement, but the results remain inconclusive, let's say. Psychedelics in PTSD treatment, for example, MDMA-assisted therapy for PTSD, reduction in trauma-related distress, and long-term remission potential is something that we are considering, especially in MDMA in PTSD disorders. What we have seen here and what we know, MDMA enhances emotional processing by increasing the serotonin, dopamine, and norepinephrine levels. We see also a reduction in amygdala and leading to decreased fear response, promoting oxytocin release that will foster trust and emotional openness. We have seen in this phase 3 trial, MAPS 2021, 67% of participants no longer met the PTSD criteria after MDMA-assisted therapy sessions, significant reductions in the clinical administered PTSD scale, lasting effects observed at 12 months follow-ups. So this is a very significant highlight, I might say, that is an important thing to see long-lasting results, and this study, for example, demonstrates this. Psychedelics in addiction, psilocybin for alcohol and nicotine addiction. We have seen ibogaine for opioid dependence and mechanism of behavioral change. For example, a pilot in 2015 at Johns Hopkins University found that psilocybin-assisted therapy significantly reduced the alcohol consumption in dependent individuals. Effects linked with increased insight and motivation and long-term behavioral changes. A small study with nicotine for nicotine addiction. 80% of the participants remain abstinent from smoking after psilocybin-assisted therapy compared to 35% success rate with standard treatments. Obviously, there is a promotion of self-awareness and perspective shifts aiding in relapse prevention. Ibogaine, derived from a West African plant, has been studied for opioid addiction treatment, interrupts withdrawal symptoms and craving in a single dose. Very significant that to say, promoting neuroplastic effects. However, there is a risk of QT prolongation, which limits its clinical applications, and research is still ongoing in this area. Now, we will talk about a study that we have published, and it was a significant study, I may say. It was, from our knowledge, it was the first international study. It was the first study that was done in international level that compared retrospectively the treatment, comparing ketamine intramuscular injections to intermittent theta burst stimulation and transcranial magnetic stimulation, which we will clarify in the following slides. What is this about? And in this study, let's start with what ketamine is. It's a racemic mixture of enantiomers, S-ketamine, and R-ketamine. It's an NMDA receptor antagonist associated with a rapid and robust antidepressant effects. Especially, we tend to see very good results in treatment-resistant depression. And the administration of ketamine was not only found to be effective in depression, but also in bipolar disorder, as well as suicidal ideation. Longer term and sustained results after repeated doses are seen and described in the literature. And by inducing and promoting metaplasticity in postsynaptic functional changes, this explains how the repeated intake of ketamine can help in long-lasting neuroplastic changes. As a drug, ketamine might provide 1 to 2 hours of a euphoric state, so it's very important to be done in a clinical setting. Some of the side effects might include dizziness and drowsiness, poor coordination, blurred vision, but these are very short-lived. And what we tend to see, ketamine can be given in different forms like IV, intranasal, oral, sublingual, intramuscularly. In our study, we use intramuscularly as it's an easy way of administration, a very well controlled environment, and being aware of the bioavailability of the IM ketamine. And a previous study showing that IM ketamine could be as good as IV ketamine in acute antidepressant effect. What is RTMS? RTMS is repetitive transcranial magnetic stimulation. which has gained a bit of widely, let's say, in international level approval following the FDA approval back in 2008 for depression, which has significant changes over time. We have seen the approval or intermittent theta burst stimulation in 2018. What we see with RTMS, repetitive transcranial magnetic stimulation, we stimulate certain different regions in the brain. These magnetic pulses produce a low electrical current that we may stimulate or inhibit different areas according to which protocols we're using. For example, if it's a low frequency protocol is below or equal to 1 hertz, and usually what we tend to say with high frequency is equal or above 5 hertz, might increase the cortical stability, where the 1 hertz and below might actually inhibit these neurons. Dorsolateral prefrontal cortex is one of the areas in the brain that is quite prominent and is quite used for treating depression, and is a very useful area that we can see different changes, including emotional processing, memory, concentration, anxiety. And we have seen the most advanced protocol of ITBS gaining FDA approval back in 2018, which can be also helpful and help people with depression, anxiety, and other disorders. So what we did in our study, we compared retrospectively two populations that received basically RTMS, the FDA-approved protocol, versus ketamine, which is a psychedelic drug. Obviously, it's been used for more than 50 years in clinical practices, especially by anesthetists to put someone to sleep or for pain relief. So our study has been published and it's available if you want to find it and read more about it in details. But in this study, we compared 12 patients that received IEM injections over a period of 4 weeks, and which was done obviously twice weekly, comparing to 12 patients who receive RTMS treatment, ITBS, over the left dorsolateral prefrontal cortex over a period of 6 weeks. So the time intervals were different. We included clinical assessment tools like the Hamilton Depression Rating Scale, Hamilton Anxiety Rating Scale, and the Beck Depression Inventory. Following these, we have compared these treatments, and obviously we're aware of our limitations. For example, the patients were not randomly placed. It was a retrospective study, but however, we did measure and we did get results, especially thinking about depressive symptoms and anxiety. So the demographic and clinical characteristics of our study did not show any differences between those two groups. It was also very important to highlight that we can see in this table the baseline characteristics of 24 participants, which did not differ in any way of number of episodes of depression, duration of depression, for example, number of unsuccessful antidepressants, etc. So what were the treatment outcomes? All three scales, obviously the Hamilton Depression Rating Scale, Hamilton Anxiety Scale, the BDI, these are studies which we did in our study basically by measuring these Hamilton scales are assessments done by the clinician, and the Beck Depression Inventory is a questionnaire which is answered by the patients. Obviously we can see the p-value here, which was quite low. Response, we've seen and we highlighted responders, patients with a 50% or greater decrease from the baseline, remitters, patients with HDRS post scores less or equal to 7, as well as in the anxiety scale and the Beck less than equal to 13. No significant differences were found in observed patients in treatment-resistant depression. So here we can see the responders, quite good significant results in the ketamine and RTMS group, which the p-value was very important to show. We have done different testing like the chi-square test to compare the groups. We see here how very similar the results are pre and post treatments, for depression, anxiety, Hamilton Anxiety, Hamilton Depression Rating Scale, and the Beck Depression Inventory. The conclusion is that, the best to our knowledge, that was the first comparative study that was directly in a clinical environment, retrospectively done to compare RTMS and IM ketamine, significant changes pre and post treatment. Obviously, as we know that RTMS is an FDA-approved treatment, ketamine as it stands on its own, the racemic mixture is not. So we see very similar results to these two groups. Obviously, we're aware that we need more studies, and that's something that always, as academics and clinicians, would like to see more and more studies to compare different sites, different group of patients, and different demographics. So other mental health applications we might think about is anxiety disorders, end-of-life distress, OCD. This is in general thinking about psychedelics. Clinical trials, obviously, we need to think about results from major studies and success rates and remain research gaps. Case studies and real-world applications, we tend to see quiet patients improving in our clinical environment that we have been using ketamine, for example, since 2019. We tend to see quite good results, especially when we combine our TMS with ketamine. We're expecting even better results. Ethical considerations are very important, so it's good and we should have an informed consent and patient safety, potential risk of misuse, balancing medical versus recreational use. We should be using it in clinical settings for medical purposes, and to be careful when someone might approach for any kind of recreational use of psychedelics. Obviously, the legal framework, decriminalization versus medical legalization. Each country has its own rules, and in some countries like Australia, we see the MDMA and psilocybin being prescribed for some time now for the purposes of PTSD or treatment-resistant depression, and there are legal challenges as unfortunately these drugs were demonized for decades, and now we can start, for the last few decades, let's say the last couple of decades at least, we can start seeing the benefits of it, or even in the past, but for some reason it was taken away by society, by medical and research proposers. The risk is quite low in terms of having prolonged psychosis. Is very low, below than 1%, especially when it's used in a clinical setting, under controlled environments, patients are screened and carefully dosed. Future research directions. Obviously, we need more and more clinical trials. These are welcome to show and demonstrate these benefits, and integration with digital health technologies and perhaps psychedelic assisted therapy advancements. And we need to think about obviously offering psychedelic assisted psychotherapy as well as an option. Role of set and psychedelic therapy, importance of the therapeutic environment, psychological preparedness, and influence on treatment outcomes. So it's very important to change our minds, our frame, how have been, let's say, been thinking for years, and how these medications or drugs have been demonized, and we have to start thinking about how to shift these social attitudes, basically. Stigma and its impact on policy and all these things has to be looked at. Conclusion and key takeaways, I may say psychedelics show promising results in mental health. Research continues to support their efficacy. Challenges remain in regulation and acceptance, and this is absolutely fine to have this, and we need to be carefully monitoring our patients when they receive these treatments. We're just highlighting some of the references and that we have used for this presentation. You're welcome to ask any questions in regards to this presentation, and I will be happy to answer. I hope you enjoyed the presentation, and I think that psychedelics, brain stimulation, and new innovative treatments are the hope for mental health disorders, and are things that are happening and are things for the future to see more.